Thank you for the introduction. My name is Marjolein van Breugel, actually. I'm from University Medical Center Utrecht in the Netherlands, and this talk will be about creating a confluent lesion in the porcine kidney with MR-HIFU. So why do we need HIFU for renal masses at all? Well, renal masses are found in a quarter of all abdominal imaging sessions, and this is increasing due to availability of imaging, and also the number of small renal masses is increasing, and small renal masses are smaller than 4 centimeters, and of this 80% is or will be eventually malignant and will ultimately require treatment. So currently the golden standard is partial nephrectomy, and this has actually quite a good survival rate, but it also knows a 15% complication rate. And if we look at the population we are dealing with, then we see that this population is aging, that they're in a poor physical condition, and they're also suffering from comorbidities, the initial reason for imaging. So maybe partial nephrectomy, so taking out half of the kidney, might be a bit invasive for these small renal masses. And therefore there's an increasing need for less invasive options, and preferably ones that do not require general anesthesia. So then there is radiofrequency ablation, there is cryoablation, but both of these techniques still require probe insertion and therefore are still not completely non-invasive. And these techniques use ultrasound or CT guidance, and therefore they don't have a means to reliably estimate the necrosis in real time. And both also have a high recurrence rate. So that's why we were thinking of HIFU, and we were not the first ones to think of HIFU. Previous studies have used laparoscopic approaches, or such as in the image in the top right can be seen extracorporeal handheld devices. And all of these studies used ultrasound guidance. This has several disadvantages. For example, there's a lack of motion compensation. There is no means to visualize the energy deposition. And there's the complexity of probe positioning resulting in a risk of bleeding and tumor spillage. And if you look at the results of all these studies, then you see that a poor outcome has been reported in 30 to even 100% of all the treated subjects. And an example is shown here where you see that there's 2 ablated areas, but there's in the middle still a viable area. So we propose now MR-guided HIFU. And this is truly non-invasive, and with the MR we can also do image guidance. We can use the MR for planning, for real-time thermometry during therapy, and after therapy we can inject a contrast agent, assess the non-perfused volume for treatment evaluation. And another advantage of MR-HIFU is that retreatment is possible, and therefore we could treat unilateral, bilateral, or multifocal kidney disease. So for this study, we designed it as a preclinical study that mimics the clinical workflow of a future patient study as closely as possible. We used a porcine model without renal tumors because that's not readily available. And the porcine model has several similarities to humans. For example, the hyperfusion, which leads to a heat sink, the cool down times you need in between sonications, the clinical time frame we could mimic, and also the lesion size and the physiology of the kidneys are similar. Differences are, as said, the tumor or the lack of tumor, and also the depth. The porcine study was a bit more superficial than we anticipate to sonicate in humans. The goals are to show the feasibility of this study, and we want to show the feasibility of creating a confluent volume with the clinical MR-HIFU setup with respiratory gating and skin cooling, and we also want to show reproducibility. So why do we need respiratory gating? Well, there is displacement of the kidney due to respiration, and therefore it requires motion synchronization of MR thermometry and the HIFU acoustic energy delivery. So we use mechanical ventilation, and what you get then is what you see here in the graph, which is the displacement over time. And you see, the inhalation phase, the exhalation phase, and then here's a long resting phase during which we can do thermometry and acoustic energy delivery. And to assess this, we use a pencil beam navigator on the contralateral kidney, and in this way we do respiratory gating for energy delivery. So another challenge is the hyperfusion of the kidney, or in humans the tumor, and therefore we use high acoustic powers of 450 watts continuous wave, and we limit the sonication volumes to small 4 mm treatment cells. This high acoustic power, in combination with isolating properties of the subcutaneous fat, create a potential risk of near field damage, so skin burns, and that's why we introduced the skin cooling in our system. And then there's another challenge, and that is the obstruction of the kidneys by the ribs, so the top part of the kidney here and also there lies behind the thoracic cage. Bone heats faster than soft tissues, and the way we deal with that now is to just make sure that the beam path is unobstructed, so we can only go for the lower poles or the middle pole of the kidney. For this study we used a clinical 1.5 Tesla MR-HIFU sonolift therapy system from Philips, and this is originally designed for uterine fibroid treatment, has a 256 elements phased array transducer, and we use volumetric ablations using electronic beam steering. And we did a study with 10 pigs, and in each pig we placed 7 of these treatment cells, which partly overlap to create a bigger volume. We used 450 watts acoustic power for a maximum of 30 seconds per treatment cell, and after treating all the cells, we injected contrast agents to assess non-perfused volume, and we performed histology to visualize the necrosed area. So this is an example of treatment planning. You see here T1 weighted MR images with a treatment cluster here of 7 cells, 1 in the middle and 6 surrounding cells, and this is the coronal view, and over here we see the sagittal view, so we see the kidney, the cortex of the kidney, and we see the beam cone entering the kidney, and here the treatment cells. This is an example of a typical heating pattern of one of those treatment cells. So on the left we have the coronal image, and on the right we have the sagittal image. So what we see is a rapid increase in temperature, so the red means 70 degrees or even higher. And if we see that for 2 consecutive dynamics, then we stop the energy delivery manually and cool down starts. I can play it again, maybe it was a bit fast, if the mouse shows up. So the rapid increase in temperature, and you can see it in both planes, and then we stop the treatment, and then we see the cool down here again. So after we sonicated all 7 treatment cells, we inject the contrast agent, and what we see here is also T1 weighted images. We see the kidney enhancing, except for this dark part where we placed our treatment cells. So that is a nice confluent non-perfused volume. Then we excise the kidney, and what is important to notice here is that although you see the lesion here, the capsule, carotis fascia, is still intact, so there cannot be no bleedings or tumor cell spillage. Then we performed viability assay, so NADH staining, and see here that the blue cells are still viable, whilst the white cells, so cells who did not take up any of the staining are necrosed. And also here we see a nice confluent volume. And this we compare with the contrast enhanced image, because if we want to go to patient studies, we will not excise the tumor anymore, and we have to have a reliable estimate of the tumor necrosis only based on the non-perfused volume. So the intended volume was reached in 6 out of 10 cases, and there is this correspondence of a median of 99% between this MPV and the staining, the non-perfused volume, and the viability assay. The 4 cases where we did have not so good results were due to overlooking of the false rib, so there we accidentally heated the rib instead of the kidney. We had residual motion due to shivering in one pig, which was probably due to the lengthy procedure. We did liver experiments in the morning. The pig was on the cooling device all day, and we think that there was a bit of hypothermia, so we had some shivering. And the third explanation is that we have insufficient power for deeper targets, so this leads to insufficient heating, and we can conclude from that really dedicated HIFU equipment is needed instead of the clinical fibroid device we're using now. So we can conclude that MR-HIFU of the kidney is feasible with the current state of the technique, but it's challenging, although we can show that a confluent volume can be ablated, and this result is also reproducible. Thank you for your attention.